Okay, let's start recording. Hello, we're going to go ahead and get started, and we'll be recording this. And this is our first run through on a new app that we're developing. And so we want to get some comments from you on our new app. So it's kind of exciting. So because we've got a bunch of data to support the app, and so and the data is pretty heavy. And so we want to talk about the Tampa Bay Cardiovascular Anatomy Score, and that's our app for assessment and reduction of cardiovascular risk and total joint arthroplasty. That's hip and knee. And we're going to compare the historical data for a binary decision, whether somebody goes to surgery or not, which is always being sought nowadays for someone to say, okay, patient can go to surgery, it's fine, versus no, patient can't have surgery, it's too risky. And so that's one decision that is frequently made, especially in the hospital, and there's an app for that. And so we're interested in image-guided data for not for assessing and deciding whether somebody can have surgery or not for a binary decision, but for optimization of the cardiovascular system when someone is going to have surgery. And so that's what we're going to talk a little bit about today. So let's just jump into this. And basically, we're going to talk about the analogy with aircraft, airplanes, and taking care of the aircraft, checklist, and getting off the ground, and how that can be comparable. And that's, are we ready for takeoff? No, we have to go over a checklist for the pilot, and there's one for the mechanic. And so basically, there has been some great work done by Atul Gawande, and actually I've got a call in for him, and he has this key takeaway called the Checklist Manifesto, and he popularized this book called the Checklist Manifesto, How to Get Things Right, and he used as a model the airlines and airplane pilots and mechanics. And so basically that's where Dr. Gawande is. He's a surgeon that does endocrine surgery, and he's at Brigham and Women's Hospital. So the standard medical clearance for surgery is basically, in today's busy practices, the cardiologist just does an EKG. There might be an echo or something, or maybe there's an old echo, but we went through a group of the patients that were going for knee and hip surgery, and all we saw were EKGs and okay for surgery. And the decision is therefore binary. Yeah, they can go to surgery. No, he can't go to surgery. Sometimes, very rarely, a nuclear resting and chemical stress test is done. And of course, we know Blue Cross Blue Shield, Michigan, 47 center study that there is a 40% false positive, 65% false negative. And so that turns out to be quite profitable for the physician, but certainly a lot of x-ray exposure for the patient and very little value to the patient. And so we're going to talk about how to better approach things. And so there's a checklist that does not exist, and that's the one for optimizing the patient to lessen the greatest risk to the patient, which turns out to be a cardiovascular glitch. And we can show you what that glitch is. And actually, it's not a major problem usually, although it can be so disruptive as to result in a major problem. And so paroxysmal atrial fibrillation is very common postoperatively or in the OR in these patients. Out of control hypertension is more common than you would suspect. Ruptured aortic aneurysm. I had a lady who was here, was going to get her knee fixed, and she said, I'm really, really worried about it. And I said, why? She said, my father died 3 days post-op, ruptured abdominal aortic aneurysm. Myocardial infarction, certainly I had a patient that had a myocardial infarction 45 days after surgery, 35 days after surgery also. Congestive heart failure, not uncommon. And then the dreaded patient with severe aortic stenosis that gets into shock during the surgery or after the surgery. So to talk a little more about that, and the standard medical clearance for surgery is just okay. So let's see. The residents in the hospital use something called the RCRI, which is a risk for cardiovascular problems, and they are interested in the operating mortality based on the patient's past history. They have a checklist: should surgery be done or not? Binary decision. So this is their checklist. It's called the Revised Cardiac Risk Index. And you can see history of ischemic heart disease, history of congestive heart failure, history of cerebral vascular accident or disease. So of the 6 factors that are used, 50% have to do with history. So what is the risk of a plane crashing by the history of the aircraft maintenance? Well, it really doesn't tell you a lot. Nobody's looking at it. It's not even digitalized. The aircraft maintenance and repair records and that history is stored in boxes and in storage closets. It's just recently some people are digitalizing it. It's not available. It has to, I don't think anybody ever checks it. And so unless there's been a problem, and then you go back and look for it. So Revised Cardiac Risk Index. This is sometimes called the Lee Index. It's kind of like the Goldman criteria from maybe 20 years ago. There's also a Canadian Risk Index, so there's several different indexes that people use. And this one basically, again, 50% relies on history. And so the interpretation of the risk score is not for the reduction of risk, but for mortality, yes or no. So what is the risk of the plane crashing based on this? Well, the very lowest risk score, which is a 1, is 4 out of 1,000 mortality. The very highest risk is 11 out of 100 mortality. So you get 7 out of 100 in between, 9 out of 1,000 in between, and then 4 out of 1,000. Any of these risks, which we consider medically acceptable, basically, any of these risks are unacceptable in the airline industry. And so let's look and see what happens in the airline industry is that we have got a risk of 1 out of 1.2 million flights. That's the risk of a crash. That's not the risk of mortality. It's the risk of a crash. And that's 0.00008%. The mortality risk is 1 out of 11 million. And so you can have a plane that goes down like this one, and it looks like everybody was successfully rescued. And so that was a structural stress that took place in this plane. And here they are on the ground. And so we're interested in the structural stress results and a failed system. That's what we want to find out about. So what do mechanics need to check and correct to keep the plane from crashing? We know that the pilot has a checklist, and so do the orthopedists. And they're extremely well organized. Professional orthopedists, they do their their checklist, and they want to standardize total joint arthroplasty, and they do a great job. And so here they are operating the plane checklist. There's a pilot checklist, and there's a mechanic checklist. And so here's the pilot, and there's a mechanic. So I'm the mechanic in this particular row, and I'm targeting strategies to reduce the risk of death and optimize outcome. That's my go. And so here's the mechanic with this checklist. Obviously, my checklist is on a computer. It's not a list. It's it's computerized, and it's an app. And so it could be on my iPhone as well. There's airplanes structurally can be imaged. And here's the Florida Orthopaedic Institute plane with total joint arthroplasty. And here's a hydraulic cylinder and a servo valve and a protection module and a way of hooking that up observing it and computerizing and reviewing an automated load and fatigue test on the entire system in terms of landing. And so there's many ways of testing the structural components of each one of these systems in an airplane, and basically reviewing that, seeing what's being stressed, where the strain is, and what needs to be done to attenuate that. So just like the heart, we can do the same thing with a CT scan, looking at the coronary arteries, and we can do the same thing with an echo, both looking at the abdominal aorta, looking at the carotids, and looking at heart and valve function. So that we have established a cardiovascular imaging data checklist, and here it is. And this is a composite, all on the same slide, but we can look at each individual component. We're looking at coronary artery disease, and we're grading it according to the CAD-RAD score, which is a score that's readily available, that's true and tried. And so we're doing that. We're looking at paroxysmal atrial fibrillation from a monitor, and that can be very helpful also. And we're looking at ejection fraction from the echo, left ventricular hypertrophy from the echo. We're looking at the abdominal aorta to see if there's an aortic aneurysm. Let's go back here. And so abdominal aorta for an aneurysm, thoracic aorta, part of our echo, carotid plaques, left atrial enlargement. We'd be looking for an ulcerated plaque in a carotid artery. Coronary artery disease can be scored, and here's a standard scoring system. And then about 5% of coronary plaques may be complex and need more in-depth analysis. And so that's where we developed the Sherlock plaque score, which is a score within a score. I want to emphasize that this particular score is only used in about 5% of coronary plaques, and it's very in-depth. The score amounts to looking at the amount of myocardium. We might send some information to HeartFlow to find out what the flow is down each coronary artery. We want to know about the stenotic lesion. We want to know about the diameter stenosis, the distance from the lumen of the necrotic core, how much necrotic core there is, the amount of fibrosis, the amount of calcification. If there's distal calcification, that may actually cause a reflective wave. If there's an ulcer in the plaque is key in this group of patients, because plaque ulcers with activated platelets can cause acute coronary thrombosis. And so the key in this particular group of patients, because they have activated platelets from bone powder, is to look for a plaque ulcer. And we'll talk about that in a minute. So this is only 5% of patients that we are involved in this kind of more deep probing of what's going on with the plaques. This is a composite of 5,000 patients that we've had plaques and have analyzed them, and we've been able to sort of establish in decades of life what's going on inside the artery. So we call it the Rosetta Stone. We're looking at genes, lipid pool, macrophages, microbiota, the arterial wall, inflammation, and as that goes across the decades of life, when you get into your 40s, you're creating little plaque pimples, basically, that are liquid necrotic core that has a risk of rupturing, and then you start doing something to neutralize that in the system. And so it's neutralized by putting some scar tissue on top of it, or perhaps by laying down some calcium. And so you proceed into fibrofatty plaques, and then fibrosis, and then calcification, and then people in their 60s have non-stenotic benign coronary calcinosis, which is a safety zone, but some will develop main left calcification and stenosis, plaque erosion, fracture, and some of the more malignant manifestations, but most will be benign coronary calcinosis, although we see some people that really never resolved the issue of necrotic core, and they keep forming necrotic core as if they're in their 40s, and then they have to keep concealing that with a cap of fibrous tissue and then calcification. So it all depends on the lifestyle of the patient and what medications they've been treated with. So we're very interested in this dynamic process that's going on. So then when you reduce that to an individual, this is where we'd like an individual to be. Minimal calcific fibrotic nodules. And that's all we want to see. Minimal fibrotic plaques, minimal calcific nodular plaques. Even dense sheets of calcium are very, very protective of the circulation. And then this is where we don't want people to be in terms of having a severe stenosis, and we certainly don't want them to be back in here. So we have a way of doing a coronary plaque dashboard on each individual patient to see where they are today. And then here's a composite dashboard of where our 87 patients are that we studied, with 24 being totally normal, 50 of them having scores that are 1, 2, or 3, which is in the 50% range of calcification. This is a group of patients that have patent grafts and stents who have coronary artery disease. That's significant, but if they have patent grafts and stents, they're protected. And then we had one patient that had a CTO, which is a chronic total occlusion, that wasn't protected and that was ischemic, but we didn't think that would be enough ischemic muscle to disrupt surgery, and we sent him to surgery and he did well. Then we had the patient with a plaque ulcer that we'll talk about in more detail, and then we have a patient over here with a caution arrow, and that's someone who has a 76% diameter lesion in the LAD, but no plaque ulcer. So we felt like she was low risk. So there were only 3 patients that in this little group that had anything that was showing ischemia. And that's these 3, of which the only one with a plaque ulcer is this one. So we weren't worried about these 2. So the Tampa Bay Cardiovascular Anatomy score involves these images of coronary artery disease, paroxysmal atrial fibrillation, which is an electrical image recording, ejection fraction based on the echo, left ventricular hypertrophy based on the echo, left atrial diameter based on the echo, carotid plaque, and we're looking for carotid plaque ulcers, and that's something we've been exploring most recently because we're interested, again, what happens with activated platelets because they get activated by bone powder, and what happens to those if there's an ulcer in the carotid or an ulcer in the heart in a plaque. Abdominal aortic aneurysms, what we see on the ultrasound. So let's look and see. We've sort of started with some low numbers for low risk and moderate risk, just a little click above, and then high risk, a click above that. We may have more of a spread in these numbers in the future, but this is our initial trial of numbers to see what happens into the reclassification and to make sure that we grab everybody that we think we need to attenuate the risk. So here's the RCRI, which is used in the hospital for our binary decision. Do they go to surgery because they're too high, because their mortality is low, or do they cancel the surgery because the mortality looks high? And so here's yes, 94.25% meet the yes criteria. The no surgery, 2.3% meet the no surgery criteria, which they went to surgery, and then 3.5% were sort of in a middle ground that they could go either way. So we took these people and then reclassified them with the Tampa Bay Cardiovascular Anatomy score, and we've got normal 17.24. We've got some risk at intermediate, about 50%, and then the high risk was 32.2%, and these are the ones that we want to focus on in trying to make some change. So here's what we did. We reclassified them by image guidance, and then we had things that we could act upon, again, targeted strategies to reduce the risk of death and optimize outcome. So it's amazing what a pile of people we have here that have a lot of concentrated disease. So we have 32 people who have left ventricular hypertrophy, which means that their high blood pressure either was discovered and inadequately treated with just one pill, and they didn't have regression of the thickened heart muscle, which you should be able to see, or that they had undiscovered hypertension that hadn't been treated yet. And so with that, we started them on treatment. And then this is amazing. 11 of them had paroxysmal atrial fibrillation that we were able to capture on the Zio. And the patients that we decided to record to look for atrial fibrillation were those with anatomical findings of left atrial enlargement, left ventricular hypertrophy, significant mitral regurgitation, or symptoms of palpitations. And so we found 11, 12.6%. And we put them on Multac and Renexa perioperatively. And of course, they're off of anticoagulation if they've even been on it. Of course, none of these have been on anticoagulation because we just detected them. And if we detect them, we start them on anticoagulation, they won't be protected because we'll have to stop it at the time of surgery for a couple of days before surgery, as a matter of fact. And so we put them on antiarrhythmic therapy with a combination of Multac and Renexa for several days before and after surgery until we felt that we could go back on their anticoagulation if they were safe. Aortic stenosis, 5.75%. Again, the important thing about that is to minimize hypotension, which you get with regional anesthesia. So we decided that we would give them general anesthesia, and they all did well. These are people that had mild and moderate aortic stenosis, not severe aortic stenosis, because severe aortic stenosis would be a reason to cancel. Abdominal aortic aneurysms or thoracic aortic aneurysms, we've got 5 out of 87. That's amazing that we found 5 out of 87 aneurysms, and one of them was large enough that we felt that we needed to stent it preoperatively, which we did, and the patient went to surgery the next week and did fine. And then coronary plaques is another story, and the number of plaques are obviously too numerous to count because we have lots of speckled areas of calcification around the vessel that's calcified plaque, and then fibrosed plaque, and then we're looking for certain plaque identities, which we showed you 3 of them, and the one that's the most important is a plaque ulcer that basically we theorize with activated platelets will cause acute coronary thrombosis. And so postoperative complications were seen in this little group of patients who basically all of them were low RCRI, but high Tampa Bay Cardiovascular anatomy scores. And so we didn't miss a single one with our score. But obviously they weren't sick enough to have their surgery canceled. So here's a 77-year-old lady that it was a mechanics failure. We failed to treat her hypertension that we newly discovered, and she got uncontrolled hypertension after the surgery and had congestive heart failure and was hospitalized an extra day. Once her pressure got down, her congestive heart failure went away and she was fine. And then the patient that we'll talk more about, which was the asymptomatic 68-year-old male with a complex coronary plaque, that predicted a myocardial infarction because it was a plaque ulcer. And because he was asymptomatic, we couldn't do stenting. But once he started having chest pain, we could stent him. And so he did have chest pain within 24 hours, was developing an acute coronary episode. And basically, we were able to rescue him because we knew it was going to happen. And so by knowing it's going to happen, we saved a lot of money. Half the cost, which was $20,000. The usual cost is about $40,000 because it's a surprise and patient doesn't get treated at the right time and gets rescued, and there's some panic, and the patient winds up in the hospital for several days and doubles the cost. And then a 68-year-old lady who was readmitted 50 days post-op for chronic atrial fibrillation with a slow ventricular response. We don't consider this our fault, but Medicare dings us for it. In terms of bundling patients, any readmission is a ding within 90 days, even though this lady could have been managed by her primary care doc and given too much medication, or she could have made a mistake herself and taken double her pills by mistake and slowed down her heart rate or whatever, that still goes on the bundling for the orthopedist, and the orthopedist is considered responsible, which is bizarre. And don't ask me to tell you how Medicare works. And then 59-year-old male admitted 180 days post hip replacement for syncope and had known AV nodal reentry tachycardia and is getting ablation for that. He's off of our schedule because he's 180 days out. And so after 90 days, the responsibility ceases for the bundled patient. But we were called by the patient as well as by the doctor. And we did have great records from our recording of his heart arrhythmias, which he was under treatment for, which had broken through. And so we were able to assist in his planning for radiofrequency ablation. And so here's the index case, which is the gentleman who is going to have a plaque ulcer, activated platelets, convergent, divergent double cone, a lipid lake with a necrotic core, and a significant stenosis that we basically estimated that he was going to have a heart attack within 24 hours of surgery. And the bone powder is seen here in the right atrium, which is like a snow flurry. And all this density, white stuff that you see where it says RA, that's the right atrium with a lot of basically bone powder that if you biopsy it and study it under a microscope, you'll find it's got fibrin on both ends and it's activating platelets. And then the other side of the coin is, the mate to that. And the mate to that is that if you have a plaque ulcer, and there's the plaque ulcer, we're showing you that dimple coming out, extending out from the channel of the coronary artery, and then we can show in depth over here on the left-hand side with the 3D image. It's 1.2 by 1.8 millimeters, and so that's basically where the platelets are going to be deposited, and that was our prediction, and that's exactly what happened. And so everyone's familiar with Powerball in the state of Florida, and the chances of winning is basically 1 out of 292 million, and the chances of predicting at any time that someone's going to have a heart attack, say within 24 hours, someone is asymptomatic, and randomly predicting that is 1 out of 111 million. So I should be playing Powerball, I think. But that would be the random prediction, and this was not a random prediction. Obviously, it was based on our science that we've developed in characterizing the morphology and composition of plaque. And so here's the patient that's allowed us to show his picture, and he says, I'm very happy I had my hip surgery by Florida Orthopaedic Institute, and also grateful Dr. Harrison and Sharon prevented me from getting atrial fibrillation, but also knew I would get a heart attack, which they anticipated and prevented damage to my heart and my hip. And that's pretty important to get both the heart and the hip, because some of the cardiologists had said, well, we got to save the heart, and, the heck with the hip. Important thing's the heart. And we feel as mechanics on this plane that we need to save the heart and the hip. And so now we're ready for takeoff, and there's the pilots and the mechanic, and we're all in the cockpit and ready to go because we've approved these patients, and we have changed the course of their convalescence and post-op complication rate. And so Florida Orthopaedic Institute, there's the plane taking off, looks like a Southwest Airline. It says TJA on the back, total joint arthroplasty, and safe flying to you for hip and knee replacement by Florida Orthopaedic Institute. And our plan at this time is to continue to enroll hip and knee patients, preparation of abstracts and submission to multiple symposia. And we have submitted to a group in London for the fall, which is for innovative orthopedic concepts, and also to the hip and knee group coming up in Dallas in November. Manuscript preparation with the students, development of a phone app with John Wingfield, who is a software writer, and then continue our webinars with case review, expand some of the use of this software into other surgical fields as well. And so that's our current summary of what we're doing, and we'd like to then see if anybody has any questions. And so I'm going to unmute this, and we've got Jarrett Moore, and we've got Joan Kraft, Linda Ferrer, and we've got Rick Alberts, Victoria Ulich, and we've got my students right here, which we're glad to have. And so, any questions from anybody today? Okay, so our Polish colleagues couldn't make it to the meeting today because they have a special meeting going on in Europe, and so we'll see them at our next meeting. And I want to thank you for your attendance, and we'll have further discussion about this at our next meeting. So thank you so much for attending, and we'll talk to you later. Bye-bye.
Thank you. Bye-bye.
Bye-bye, everybody. Thanks for coming.
1.6, 1.7.
I'll close this down. Today's the last day for the heart abstract. You want to send your abstract in? American Heart.
American Heart.
Yeah, you got to look it up, and we'll send it in today.
What is that?
This is called a HIDA scan, HIDA for, sorry, tongue breaker long name. That is the radio tracer looking for polycystitis. We can differentiate acute from chronic polycystitis if present. Here it's first like any kind of contrast that you give into the vessel. First it goes into the heart, then into aorta and the cervix. Okay, so long perfusion. And
Shutting down.